You're listening to Season 3 of That's Not How a Baby Sleeps. I'm your host, Alicia Daishon, and I'm joined by my co-host, Eleni Katsinis. We're not your average sleep consultants, no cry it out or sleep training at all for that matter. It's nice to meet you.
You too. Hello.
I've been following you for a really long time, and when Eleni suggested having you on, I was like,
Yeah, let's do it. I've been following you as well. I don't know for how long, probably a long time.
Awesome. Well, do you want to just talk a little bit about yourself, introduce yourself?
All right. Well, my name is Lauren Sloan. I'm the founder of Spirited Baby Sleep and Wellness. I'm a registered nurse, certified lactation counselor, and I'm a mom to 3 neurodivergent boys. So we have an 18-year-old, a 14-year-old, and a 4.5-year-old. So that's sort of where all of this started. Our 2 oldest are my husband's from a previous marriage, and our 4.5-year-old was my first time mom experience with a baby. So when I met our older 2, they were 7 and 12, I think. So that was in 2021 that I had our youngest, and he never slept, died 15 hours a day, was deemed colicky, and we were just sort of sent down all of the wrong paths first, and there was a lot of sort of being dismissed and, a lot of watch and wait approaches and those kinds of things. So I got my certified baby-led sleep and wellbeing specialist. I did that through Isla Grace, and the rest is kind of history. So that's how I got where I am.
Awesome. How did it feel like kind of navigating being a first-time mom and just working as a medical professional as well? Like, did you find that quite difficult?
So I had hyperemesis gravidarum when I was pregnant, so I just puked all the time. So I was actually working in a COVID ICU at the time, and it just wasn't sustainable. So pretty early on in my pregnancy, I had to just be at home because I puked, and I have POTS and some other things going on, and my heart rate was really high. So I was sort of out of the medical field while I was pregnant and then after, but it definitely made things a little bit more complex when I was delivering and sort of navigating through the medical system for him, because a lot of the providers and people that we were engaging with were people that we knew, or I had worked with or rounded on the floor with. So it definitely made things a little bit more complex. And we were both in this sort of privileged position. Our neurology consult that we got was because I went in and I said, hey, I want a neurology consult. And I knew the doc, so he was just okay. So we had a little bit of that privilege, but also the medical system sort of failed us in a big way, even though we had a lot of connections. And so I think that is probably more true for parents that don't have those sorts of connections.
Yeah, absolutely. It's really not set up for babies who are colicky, as everyone likes to call them. Okay, do you want to talk a little bit about just how highly sensitive, neurodivergent, medically complex babies are often dismissed? Because I feel like that's a pretty common occurrence. We see it all the time when we're supporting families.
Yeah, so I think, I get a lot of kind of pushback on my page, a lot of criticism for being a fear monger, or I'm creating anxiety in new moms because I speak a lot about mostly autistic babies. So, my belief is that autistic babies are born autistic, and we can see a lot of behaviors that are typical in every baby, in autistic babies, and what matters is the frequency and intensity. And so what we see are inconsolable crying, babies who cry inconsolably, who can't be put down, they have extreme sensory sensitivities and those kinds of things. And on the opposite side of that, we see who we don't see because they're not coming to us, are babies who sleep through the night from day 2, who don't care if they're picked up, so both of those things are sort of something that would make you want to be curious. And there's just not a lot of interest in that from the medical community. And the response is, every baby does that. We'll watch and wait. I'm not concerned. And the big picture is that frequency and intensity matter. So if one of the things I talk about is my baby didn't make eye contact with me until he was 14 months old. So a lot of people are well, it's a sleepy cue, right? If your baby averts their gaze, maybe they're tired. So all babies avert their gaze. First of all of them don't, but most of them do. But do they do it all the time? So that frequency and intensity piece matter. And I think those questions don't really get asked in a medical setting. And so a lot of that gets missed. And I think there's a couple of things going on there. As a physician, you've taken an oath to do no harm. And are you doing no harm if you're putting a baby through unnecessary tests, unnecessary procedures? And so I get that part of it. But when you're looking at a patient that is symptomatic, you're looking at a baby that's symptomatic, right? They're crying all day. You've ruled out everything else. There are so many resources that are out there that are just not even shared with parents. So I think that watch and wait approach is really harmful for even highly sensitive babies, because what we're talking about is a more sensitive nervous system and like more responsive or under responsive sensory system. So even those babies benefit from like occupational therapy and getting a sensory profile. So even those babies in a medical setting would benefit from an early intervention referral. And that's just sort of not what happens. We get this colic diagnosis and parents are just kind of left to figure that out.
Yeah, it's not even really considered. Yeah. You know, they look at like reflux and stuff. I mean, we all know that oral ties, stuff like that's always missed. The sensory stuff, like that's something that, you know, I know the basics of just from being certified through Isla Grace, but it's not my like area of expertise. I know basics, and it's like, okay, let's refer out to an occupational therapist. And I don't think that's something that a lot of people take into consideration. Well, most sleep consultants don't take into consideration when looking at baby sleep. It's just these easygoing babies that here's a 6-month-old schedule that should work for your child. Oh, it doesn't work? Okay, it's time to just sleep train. And it makes me so uncomfortable to think about all the babies who might have sensory issues and are just left to cry.
Yeah. And I
imagine sleep training probably doesn't work for them.
No, it doesn't. It actually escalates for them. And those are the babies. And I talk on my page a lot about like the physical risks of sleep training, because the argument we see online is like it hurts attachment, like it's harmful for attachment. And like, you know, you've seen all of we've all gotten into some like in the weeds beef on Instagram about how we feel about these things. But you don't need the evidence to say that there's a physical harm. Like we see it. We know that babies are aspirating when they're sleep training and ending up in the pediatric ICU. Like I just had a case, not this month, but last month, where the mom, I shared the story on my page, so you can link it if you want. It's just a post. But it happens. Like any time that you put a baby or any human with lungs in a situation where they're crying and vomiting at the same time, it's a high aspiration risk. So if you're going into your pediatrician's office and they're saying, well, they're 4 months now, you can try sleep training, but they're not telling you they're at risk for aspiration when you're doing this. And if they have an undiagnosed seizure disorder, we're lowering their seizure threshold, so they're at a higher risk for seizures while we're doing, like, where's the informed consent? You know, if you're going to a pediatrician's office and they're giving you these recommendations, we're really not giving parents the informed consent that they deserve, because there definitely are physical risks to sleep training.
Absolutely.
In my opinion. Yeah.
No, I completely agree. That's terrifying.
Yeah.
And I was initially, I don't know if you know my background at all, I was initially certified as a sleep trainer.
Yeah. Were you?
Right. Yeah. Oh, yeah. That's how I got into all this. We tried sleep training with my first. It worked. And I was like, wow, I want to know why it works. And I didn't want to go back to my previous job. So I was like, I'm going to get certified as a sleep consultant. So I'm going through all of the different sleep training methods. And I'm like, so like, how is this working? What is making them self-soothe? And they're like, oh, they're just self-soothing. But how? And I was like, I think we tried it around 6 months. 3 months later, I was in the middle of my certification, and she went through her 9-month developmental progression and started waking up, and I started responding, obviously. And they were like, well, now you have to retrain her. I'm like, but I taught her this life skill. Like, what are you talking about? And then, of course, I went down that whole rabbit hole and stuff, and then found Lauren Grace and was like, hey, this is actually not what's happening when we're using sleep training. But in that certification, they had like protocols on like puking and stuff, which is like so disgusting. Yeah. It's like, well, you know, you just go back in and you clean it up and then you continue the sleep training. And I was like, sorry, what?
Yeah,
like,
it's scary. But
really,
what
really
a testament to like, you don't know what you don't know until you know. Like, I mean, you were even certified and you were practicing it and it worked. Like and that's why it's so important to talk about it, especially if you're a medical professional recommending it, and like give all of the information. Like maybe we don't have the research to say definitively that this can impact their mental health or this can impact their attachment, but we know they're an aspiration risk. And I think what people don't understand, and I don't want to make a big spiel about aspiration because it's not super common, but a lot of people will say like, well, my baby wasn't at risk because I responded immediately. But you can respond immediately and you're already too late. Like it's the puke and then the breath, right? They breathe it in immediately. So there's just sort of a lack of understanding about how that risk exists.
Absolutely. In your experience, these kind of like traditional sleep training methods, where do you feel like they fail the parent and obviously the baby as well?
Yeah, so I think in highly sensitive and neurodivergent babies, especially, so I think every baby, but in these babies particularly, I think nervous system wise, it is a failure. I think sensory wise, it is a failure. But also, we have a lot of, in autistic children, there are a lot of like comorbidities that or like co-occurring conditions that occur when you higher instances when you are an autistic individual. See babies with hypotonia, so like that low muscle tone. We see limb apraxia, so like their brain isn't communicating well with their muscles, and so there's some movement disorder there, and just some things that can really impact sleep if you have like apraxia. So are we feeding well? And feeding and sleep are intricately intertwined, and a lot of the sleep training culture or like that sort of advice removes like that parent contact at night. And so if you have a highly sensitive or a neurodivergent baby and they are using the suckle to regulate all night, like not only are you like training them or teaching them this skill, but you have perhaps removed the only regulatory mechanism aside from you, which you are removing in sleep training. But if they are reliant on that suckle to get to a parasympathetic state to reach sleep, then they just can't. So I think, especially in autistic babies, that can be really challenging and backfire.
Absolutely. What are some more red flags that baby sleep challenges are maybe not directly related to just like normal infant sleep that you kind of see?
The thing I see most common is actually low ferritin,
Okay.
which happens in a lot of babies. I'm sure you see it as well too.
Yep.
But when we're talking about an autistic population, there's a lot of gut microbiome differences. So we're also looking at like absorption issues. So we can see increased instances of low iron, and there's more complexities around iron. So I don't really have to get into iron if you don't want me to, but it's actually pretty complex in you can't just supplement and then expect that it's going to go up. So your body tightly regulates iron. It depends on your cofactors. There's a large percentage of babies who are not orally responsive to iron, so they don't respond to oral supplementation. And you sort of have to, especially an autistic baby, like figure out why they're not responding to iron if they're not. So the protocol is like you do 12 weeks of supplementation and you recheck, and you have to get ferritin and the iron panel to see if they're not responsive. Why? Is it because serum iron is high and then there are things we can do about that? Is it because they don't respond to oral iron supplementation and then we can do IV iron supplementation, something about that? So it is kind of like more complex, and I have a whole article, like I could talk for an hour about iron because it is a little bit complex. So I have an article that I can link, but for sure the most common thing that I see is low iron and a lot of airway stuff. So higher instances of oral ties, higher instances of obstructive sleep apnea, sometimes central sleep apnea. So if we're more prone to like sort of this brain, body, muscle discoordination, those sorts of disorders, like then we are more likely to see like a central sleep apnea, which is not related to obstruction. And then more obstructive sleep apnea because we have lower muscle tone, oral ties can lead to, so just a lot of airway things. And then we have some really strange like allergy stuff. So higher instance of babies that in the autistic population can have things like mast cell activation syndrome. So we'll see babies who appear to have terrible allergies, but they're going to the allergist, they're doing all the things, nothing's coming up, and parents are like, I don't know what to do about this. So we send out for mast cell activation, and it's a long road, but we ultimately get a mast cell activation diagnosis. And I actually just worked with a mom recently who, when she came on to work with me, already had, and I think her kid was like 2, and she already had that mast cell activation diagnosis. So that was pretty impressive. Like there's definitely, you hear about hypermobility and all of those kinds of things and autonomic dysfunction. So do we not sleep well at night because our heart is racing? Or so we have some of these like physiological things happening that a more sensitive sensory system is going to be even more sensitive too. So that makes sleep even more difficult.
What is the age that they typically diagnose children with autism or on the spectrum?
Yeah, so here it's around two or
Okay.
older. The problem is you don't really get anybody to take you seriously until you're almost 2, and then you get put on a wait list, and the wait list can be anywhere between 2 and 4 years. So I always tell parents, if you have any sort of suspicion at all, self-refer to early intervention. You don't need your physician. You can just self-refer, and then you have access to physical therapy, occupational therapy, speech therapy, and they're free services, in-home services. And I have a guide you can link that kind of walk people through how to access these. Most people, most families that I work with, I do the referral for them if it's necessary, or if that's something that they're interested in. And like, you don't need a diagnosis, and like, there's no harm in it. So like, your baby's not going to experience harm because they were seen by an occupational therapist, or even if they work with one, right? So it doesn't, there's not a label, or really, there's a lot of parents that are kind of fearful of sort of labeling their baby too soon or something like that. But it can be really beneficial. And as soon as they don't meet the criteria for that anymore, then they just graduate them out of that program. And if they turn out to be autistic or have something else going on, then that program will carry them through 3 years old. So the program is birth to 3 in the United States. And then at 3, transition them into early childhood special education, which also offers PT, OTST, and early childhood educator. So really, the services are there from birth to 6, and we just don't use it, or it just doesn't get, the message doesn't get out. Yeah.
Yeah, okay. Because that kind of had me thinking. I'm like, we work with all these children, and then if we're not getting any diagnosis till later, like even now, I still have some parents where they're like, there are some sensory issues going on. Sleep, we got it to like a little bit of a better place, but it's still, things are still not great.
Yeah. And if we talk about like ADHD, because that's under that neurodivergent umbrella too, like that diagnosis doesn't come until 6 or later. So, and we see sleep disturbances in individuals with ADHD too. So, yeah.
Yeah. We were looking into it for my 4-year-old.
Yeah.
Again, she's still so little. That was kind of the answer I got, and obviously I do have some tools and that I can utilize, but it was just something kind of going into, she's starting kindergarten this year. I'm like, I'd like some tools, because my usual emotional regulation things that I use with my oldest are really not working with her. And then it took us for a long time to get into the doctor and stuff to see her and everything. And by that point in time, we'd come up with some pretty helpful things.
Yeah, and so is she's going to start kindergarten? So the school, if you request with the school, then they are obligated to do an assessment for you and potentially give her access to PTO-TST if it's needed. It's not always needed for ADHD, but you never know. Like the occupational therapy piece could be really helpful.
For sure. It's interesting because like with her, like sleep, I was like, it didn't really bother me. But if I think about it, I'm like, she sleeps with her older sister. They bed share, which I love. My oldest is 7 and my youngest is 4. And she just snuggles up to her now. But for like up until probably 6 months ago, she would end up in my bed at some point in time, and I don't care. Like, it just doesn't bother me. But, you know, she was still waking up at night, and I know if I hadn't put her on the specific side that I put her on the side that she would be on in my bed. I made them switch spots, and she immediately started sleeping through the night because she was like snuggled up to her sister and just seeking that extra input from her. I know she would still be waking up, but she is really, really sensitive to just different transitions. My mother-in-law is battling brain cancer right now, so we have some family things going on, and she's been really struggling from that aspect. You know, like little tiny things really, really do trigger her and stuff, and she has a really difficult time.
So I actually offer a transitions workshop, and it's an hour and a half, because when we're talking about highly sensitive and neurodivergent babies, a lot of them struggle with transitions. So when we talk about sleep is like the biggest transition. Like, you're going from alert to asleep, so your state of consciousness is changing. It's physiological. Your breathing is changing. Your heart rate is changing. And if you have a heightened sensory system, like, you really notice all of those things. And then like, it's a transition in general, as like all the other transitions are. And so if we focus on transitions during the day and we make transitions feel safe in their body, so we're working on like preferred transitions to preferred, like we're going from a preferred activity to a preferred activity, and we can like slowly move through that. I'm like really like honing it down here. It's an hour and a half course. But if we can make them transitions feel safe in their body, then during night sleep when they're transitioning away from us, or even if we bed share, that can still be like a physiological transition, then that can really impact. And that was actually probably the most beneficial thing that we did for our youngest, was work on those transitions, because every transition was hard for him, like getting in the bath, getting out of the bath, getting in the car, not playing like going from playing blocks to playing with Play-Doh. Like any sort of like transition was really hard, so we had to be really strategic about that and support transitions. And it's not fast, like it is not a fast thing. We probably spent 9 months working on it, and we spent about 4 months just doing preferred to preferred when he was in a regulated state, but it absolutely probably made the biggest difference that we noted in his sleep.
I had to implement a button system with her. I got these like little light up like push buttons,
Yeah.
and I had routine cards because my oldest was late for school so much last year because just getting the younger one out of the house.
Yeah.
And it was like with my oldest, it was like, okay, we set a boundary, we support the emotions with it. The emotions would eventually taper off and we'd move on with her day. That didn't happen with her. It would be like an hour long, absolute just screaming fest. There was one point where I put her physically in the car, strapped her in, and she took her boot off and threw it at my head while I was driving and knocked the car into neutral and almost killed us. So like things like that. And then I was like, okay, I'm going to try a different approach. And we got the little push buttons and stuff and the routine cards, and I had them Velcroed so I could switch it out for bedtime, switch it out for just like leaving the house, anything. And I just turn on the lights and I'd be like, Luna, go do your buttons. And she'd be like, okay.
Yeah.
And just go do it all. And I was like, what?
Yeah.
So like just different tools like that I would never have really thought about with my oldest. But yeah, transitions have still hard, and we do sometimes have to implement the button system again, but they definitely got better after we started kind of having that structured visual
Yeah.
set up for her.
Yeah. And so when you do, I think like a big piece of like the sleep puzzle is that when you do things like that during the day, like you talked about like this like extreme dysregulation where she's throwing things at you in the car, and like that, like it's all cumulative in your nervous system. So if you are going about your day and you're struggling with transitions and you're getting bumped out of your window of tolerance, like you're just in this sympathetic state and you sort of remain there, and then that makes sleep really hard. So while this button system that you use during the day really wasn't like for sleep, like it certainly impacted sleep because it was helping her be more regulated during the day.
No, that really hits home when you're talking about, them being dysregulated and then that kind of continuing through the rest of the day and kind of spilling over into everything, because that's her.
Yeah.
100%. And if I lose my temper, anything like that, if the tone in my voice changes, the rest of the day just kind of spirals downwards.
Yeah.
And you see all the behavior stuff come up. And I'm like, well, I did the wrong thing in that moment.
Sensitive.
And I escalated it and made it so much worse.
Yeah, they pick up on everything.
And then bedtime's a disaster.
Yeah. And a lot of times I see in autistic children that, we talk about a lot like this transition into sleep, but what can be really difficult is the transition out of sleep. And so parents have a really hard time getting out of the door in the morning, and they're like, my kid is just defiant or oppositional to all these things that we're doing. And if we really think about like where that stems from, like what does that transition from a sleep state to an awake state look like? And instead of fighting dysregulation for 45 minutes every morning, can we instead do a really rigid child-led routine for 10 minutes when they wake up? So our youngest wakes up, his eyes pop open, he alerts to me that he is awake, and I go get him. I say, I missed you while you were sleeping, and he gets a muffin in his iPad. And the screen time thing really wigs people out, but he is not a kid that's on his iPad all day. He could care less about it, so that works for us. If you have a child who clings to that iPad and then you have to transition away from it, that is a terrible idea. And you could do like a Tony's or a coloring book, but like whatever your child likes, throw that into a rocking chair or a couch or a cozy corner or whatever for the first 10 minutes of the day, and let their body like physiologically move out of that sleep state, and then bother them about changing their clothes or brushing their teeth or eating their breakfast. It can, like, people are like, well, I don't have enough time. I don't have 10 minutes in the morning to dedicate to this, or 15, but you
don't have 45 minutes of dealing with a giant meltdown.
But you're spending 45 minutes, sometimes more, with all these meltdowns. And does it all stem from that waking up transition? Sometimes it does.
That's really interesting. Yeah. Do you find children who are on the spectrum to have lower sleep needs? Is that a common thing?
So I find them to have out of range sleep needs. So either low or high. And
Okay.
those high are like, again, not the parents that are coming to us, but they are showing up in my DMs and showing up in my comment section. Like, hey, my kid got an autism diagnosis at 4 and he never cried, didn't want to be held, slept for 20 hours a day. By 2 weeks, he was sleeping through the night. So I hear anecdotally a lot of that there was a lot of like very high sleep needs. And in our case, we had a very low sleep needs, and most families I work with, they are trying to push like 13, like that 2, 3, 4 wake, when that schedule like really gets people, because it only serves a baby with a 15-hour sleep need. That's it. One baby. It's a 15-hour sleep need baby. And if your baby doesn't have a 15-hour sleep need, then that schedule doesn't work for you. So there's a lot of that, and their baby may have a 10. So like that's 5 hours a day that you're like fighting their biology and dysregulating them and dysregulating yourself, and it just really snowballs. Yes, either much higher or lower sleep needs.
That's interesting because, yeah, we don't see a lot of the high sleep needs kids because they just sleep.
Yeah.
I feel like I only work with low sleep needs, and both of mine are exactly like that. My husband and I have low sleep needs, though, too. So we just made 2 children who are exactly like that, dropping naps by 2 and
Yeah.
all that.
Yeah. And so I also have low sleep needs, but another thing is a lot of autistic individuals have unique sleep chronotypes. So they like want to sleep from like 1 a.m. to 7. Like they're just like night owls or like early birds. Yeah. So my son is a 1 a.m. bird and I'm an 8 p.m. Like, so we really have this, we don't have a goodness of fit there, and that's been hard. And you can work on those things. There's things you can do to shift that, but you also have to know that if you have a child with a certain sleep chronotype, they will move back to that if you don't continue doing what you're doing to sort of keep it where it is. And it's not like harmful to adjust their schedule one way. It's just like work, because if they nap longer, so you let bedtime go later one night, then the next night it's later and the next night it's late. So like you really have to be diligent if they have a chronotype that's much later, because it will definitely revert back.
Yeah, you're describing my house to a T right now. Because mine will both sleep in.
Yeah.
Which is great. But if we have a late bedtime and then a sleep in, the next night is bedtime is the same time. We're pushing to 11 o'clock bedtime. And I got a phone call yesterday from daycare. My daycare lady was like, hey, Luna's been really emotional today. Is it okay if I let her nap a little bit? I'm like, no, I'm coming. I'll come get her at lunch. I'm like, I would much rather her go to have a little bit of an earlier bedtime than nap for, 30 minutes and that be pushed out to a 10 or 11 o'clock bedtime. And that's what we were dealing with all last year. She's finally doing full days again, but I was picking her up halfway through because I'm like, I can't do this. She's like, I have to, all the other kids are napping. It's a small, like in-home daycare and stuff. She's like, so like, I need her to nap a little bit. I'm like, I can't. I'm like, even with the 45-minute nap she's doing, she was pushing out till 11 o'clock. And then I'm waking her up at 7. She's falling apart because she's still tired. And then we're just doing it all over again. Yeah, having to stay consistent with that morning wake up time with her to kind of keep the day on track. Like on the weekends, the girls will go and like watch some shows and stuff in the morning. My husband and I will just kind of curl up on the couch and like go back to sleep. But we have to get them both up so that bedtime stays on track a little bit. Like 9 o'clock is a standard bedtime in our home, which is so funny when we see the 7 to 7 pushed. Like I've never had a 7 o'clock bedtime.
Yeah.
It'd be wild.
Yeah, I know. And so like you're talking, so that nap in daycare and stuff like that can be really it's really challenging for a lot of people. And like you said, like they won't not do it. And I've worked with parents and I'm like, well, will they do it for an hour? And they're like, oh, they won't wake her up. And I'm like, well, how long is she sleeping? And they're like 3.5 hours. Like, what do you mean they won't wake her up? Like, so that's a real struggle. But also when we're talking about like autistic toddlers, preschoolers, like my 4.5-year-old still naps and he just like can't make it like regulation wise without it. So he needs that 30-minute to an hour nap, and we just have to take the late bedtime because his nervous system just can't do it. So like it really just depends on the kid and like what is like supportive of their sensory and nervous system needs. And people get really triggered on the internet when I'm like, well, he doesn't go to bed until 11:30. sometimes later, but he still naps during the day, and his wake time is 7:30, but previously it was 9:30. So like he's getting plenty of sleep if he's like, even if he went to bed at midnight and slept until 9:30 and took an hour nap, like the sleep is there. It just looks different.
Yeah, just looking at it over a 24-hour
Yeah.
period is just this obsession with nighttime sleep and it being 12 hours
Yeah.
all the way through. Do you want to talk a little bit about just like regulation challenges that you see kind of show up at nighttime, at bedtime with neurodivergent children?
Yeah. So I think everything is really, so when I talk about sleep, when I'm working with families, I talk about sleep through the lens of like the time that they wake up in the morning. So like the second they open their eyes, we're already, whatever happens after that, like is going to impact their sleep. It's all important. So when we talk about like a highly sensitive or a neurodivergent baby, like a lot of times what we're referring to is their nervous system. And I really didn't have like the language or anything to understand this when I first started out. And I found Natalie Brunswick on Instagram. I don't know if you follow her. If you don't, I'll give you her handle. She has like a Raising Us, like a community online, and it is wonderful. But really from her, she gave me the language about the window of tolerance and flexibility within the nervous system. And so really like that's like the secret sauce. So when we are talking about like a highly sensitive or a neurodivergent baby and they're really dysregulated all the time, what we're really looking at is like their nervous system, and they have a narrower window of tolerance, and so it's easier for them to bump out into that state of dysregulation, and they may have less flexibility within that nervous system, so it's harder for them to get back in. And so when we talk about babies that have to be bounced all the time, or they'll only sleep with constant movement, or, you know, all the things, it is because and if they're not doing all those things, they're very dysregulated, they're colicky. It is because they have this decreased flexibility within their nervous system, and they just require a lot more input to get back into that regulated state. You know, I have a few posts about it, and I used to talk to families a lot about like when my baby was young, like it almost felt like too much. Like, I'm bouncing you real hard, sir. And like I had to do all of it. Like I sometimes had to like bounce and rock. Like it was just like I had to like completely bombard his sensory system to get him to like snap out of it. And like sometimes I would turn like the sound machine on, not all the way, but much higher than it should have been. So like the sound machine would be up, I'd be bouncing and rocking, and like finally he would just soothe. He loved the vacuum, like anything that was like the blender, like anything that would just like override that and sort of reset for him. So like that's that like decreased flexibility. Like it's just harder for them to get back to that regulated state.
That's so interesting. My 4-year-old is also still rocked.
Yeah.
Yeah. In the rocking chair. We have a boundary around that. We're not standing and physically rocking you, but we will sit in the rocking chair and rock with you. She will sometimes lay down. She also has low iron. A lot of these things that you're talking about. And I remember during like kind of that witching hour, I'm like doing these like jiggly aggressive things, kind of like holding her neck at the same time while I'm jiggling her to make sure I'm not injuring her. But she needed that like aggressive bouncing that my husband would come upstairs and be like, what? I'm like, it's the only way she'll calm down. I don't know what to do with her. At this point in time, I've already done Lauren's course and I'm like, I have 2 sleep certifications. What am I doing right now? But just different child.
Yeah, it's hard.
And of course, everyone's still expecting these babies to somehow self-soothe to sleep.
Yeah, it's just not possible. Yeah.
It's wild for a baby who is easygoing anyways. Yeah. Like it's still...
Well, it's wild for me. Like...
Yeah.
Like I'm, especially lately, I am just like a dysregulated hot mess. I'm a dysregulated mess. And like, I'm not self-soothing. So yeah, it's tough.
Glad we're on the same page with that, because I'm not. I struggle with my own emotional regulation, so expecting the children to be able to do it is interesting.
Yeah.
Okay. You touched a little bit on like feeding an airway and stuff. Do you want to talk a little bit more?
So some hot takes here. So in my professional opinion, we have no business weaning a baby before a year old, night weaning a baby before a year old. One, it's like SIDS protective. So if your baby is waking up to eat in the night, like it's SIDS protective, 1. 2, it is like a baby's most innate form of regulation is co-regulating But then second is like that vagus nerve. So that is like that tiny baby brain that they're born with, that amygdala, that really like animalistic brain, that is what soothes them, is that vagus nerve. And they do that through suckling. So we see a lot of babies that latch all night long, which can be silent reflux, oral type, like that can be a thing, but it can also be a baby with a really rigid nervous system, and that is how they're getting into that parasympathetic state. So that suckle is what is getting them there. And so we talked about this a little bit, but when we remove that, like you're taking away their mechanism to regulate. And we have a lot, like I worked with a lot of families weaning, like a 18-month-old or a 2-year-old, and we're working on night weaning, and it's really impacting sleep. And we see like this profound impact on sleep, because that is how, like, she's like, a lot of moms are like, you know, they nurse all night, so how am I supposed to move away from this? And so we need to support that sensory mechanism in a different way. So that often looks like, can we do like yogurt or something thick through a very narrow straw, so that they're having like a midnight snack that is supporting that sucking, that vagus nerve? So it depends on like what it is. Like, are they needing that vagus nerve like stimulation, or is it like an oral sensory thing that's soothing? And then do we have a midnight snack that's pickles and olives or something sour? So it can really vary and like really pretty dramatically impact sleep when we're talking about like nursing and weaning. But what we also see kind of go hand in hand is like this low ferritin. The lower your ferritin is, the higher your leptin is. And when your leptin is high, you don't eat. So we have a lot of babies or toddler, older babies, 9 months on, and toddlers and preschoolers, and they won't sleep, they won't eat, and it's all kind of related to, like, we know that a baby that's not eating isn't sleeping well. They are deficient in all sorts of things that impact sleep. But is it related to this iron, ferritin, leptin mechanism? So it's all kind of complex, and it takes a while to sort of figure that out.
Totally. So many layers. Yeah. That's interesting. I didn't know about that with ferritin. Mm-hmm. More iron stuff.
So if I'm working with like over one, a toddler or a preschooler, and they're in some sort of therapy or preschool, or perhaps they're having a language explosion. Whenever we are working with someone who is doing something that is not child-led, and I'll use the language explosion one because a lot of parents have a lot of sleep around the time that there is like this developmental leap of language. And we know that like one thing can be in the driver's seat at a time. So like when we're learning new skills, sleep can take the back seat. But also what happens is, especially in parents who are working with therapists who are not necessarily like affirming, we see things like maybe a speech delayed child, or even a toddler who's just learning, wanting water. So they'll hand guide their parent to the water. They'll give an approximation. So say like, wah, or something like that. And then what happens is parents have been coached to be like, say wah wah, say wah wah. And so what we're doing effectively is putting in a million micro demands on their nervous system all day long, and that significantly impacts sleep. Because what we should be doing is, when they communicate with us, even if they use no words, if they hand guide us and point to the water, we don't make them perform to get their needs met. We just meet the need and model it. You want wah-wah. Like, we don't put demands on their nervous system all day long. And so when we're in therapy or in preschool, it's tough to find people that are nervous system and neurodiversity affirming and stuff like that. And so I can see sleep disturbances a lot of times in those sort of situations.
It's just too much.
Yeah, micro demands all day long, and we're having to perform, and that's tough. It's tough for them.
Yeah. And you get the constant use your words.
Yeah, and we don't like it. We don't like that.
I can confirm my youngest doesn't like it. It doesn't go well. It usually just sends her over. What gets missed when the professionals are looking at sleep and isolation? Like the constant obsession with like separation. with our children? What do you feel like gets missed from that aspect when you're working?
So I sort of think that our pediatricians don't have or shouldn't be really dealing with sleep unless they've had some sort of training around it. Like, we know there are some studies out there, some information that have been submitted that, you know, your pediatrician or your standard physician or whatever gets an average of 15 minutes of training during their medical schooling. And we know that like a board certified physician is only required to answer like so many questions every so often, and those questions may not even be applicable to their practice to like meet the certification needs for their certification, like the education requirements for their certification. So there's like nothing out there really holding any physicians accountable to educating themselves on this. And I think that like one of the things that I have seen really frequently recently is this like behavioral insomnia of childhood diagnosis. I don't know if you've seen it, but it's essentially any child that won't go to bed now has this behavioral diagnosis, and it's in their chart, and they typically say, like, if you're requesting medical records, they say some pretty negative things about the parents who have poor sleep hygiene and aren't consistent and have done some coddling. Like, there's just like crazy things in there, but the recommendation for that is cry it out. And so I've shared some pamphlets and wrote an article on it because it's likely these neurodivergent, highly sensitive, like, in no world is a child not sleeping just because they don't want to. Like, there's something going on, and perhaps it is connection. Why are these not staying in my ears? Perhaps it is connection, like their connection cup is not full. Perhaps it is environment or whatever, but there's something there. And so when we go in and we, you know, the most stubborn babies get this diagnosis, and because they're stubborn, we just cry it out, and if mom can't handle it, put in her earbuds and go watch a show. It's incredibly dangerous. And like, I don't want to get like political or bring hot topics up, but what I see in practice a lot is parents who tell me at their 4-month appointment that just in casual conversation, the pediatrician says something like, well, you can stop feeding at night and you can sleep train if you want, which I don't like in general, but typically what happens at that 4-month appointment is we also get wellness shots. So I don't believe that we should be giving a vaccine and then encouraging that mom to go home and put AirPods in and watching a show and not monitoring her child. And like, I just think that there needs to be a little bit more critical thinking around that, and more like, it's work. It's a lot of work sometimes to figure out like why they're not sleeping, especially if it's like allergies. Like, the road to allergies is like long and expensive, and it just is a really long road. And so I get that like providers don't want to put parents or babies through that, but if you have a symptomatic baby, I have a family that I'm currently supporting had a sleep study done, and the sleep study showed moderate sleep apnea, and the ENT told mom that it didn't matter because there were only 6 periods of apnea during the baby's sleep, and he has seen upwards to 100. So the 6 didn't matter. And then I talked to mom a little bit more and found out that they really struggled at the sleep lab, which is pretty typical. So this 6 periods of apnea happened in 2 hours, 2 hours of sleep that they got there. So, and we know that the child is likely in lighter sleep in a sleep lab, and like, these apneic episodes are likely more prominent during deeper stages of sleep. So it's probably happening more at home. Like, it's really just wild, the things that are happening that, I mean, I'm aware of because I have some background, and I was lucky to have gotten to work with a lot of physicians who are willing to answer my questions when I have them. Like, is this crazy? And they're like, yes, that is crazy. But there's just a lot of things going on out there that like parents wouldn't know. They wouldn't know. So I feel like what started as sleep, like my intent was to like, we don't want to pathologize sleep, and let's set normal, you know, like, let's set expectations, and let's get rid of, you know, you're here. But like, I can't even help a family with sleep because we can't get past the red flags, and we can't find providers that want to help address them or take them seriously. So it's definitely been challenging.
It's ridiculous. There's been so many families where I've done their intake, done the initial assessment. I'm like, we need to rule all of these red flags out which again can take
Yeah.
months. And it's like, okay, and then we're touching base 6 months later once they've gone through, if that,
Mm-hmm.
the whole process of making sure that everything's okay from that aspect. And I get a lot of pushback with iron. Like I'm in Canada and it's not standard.
Yes.
We don't
Yeah,
test at 12 months at all.
for sure.
Like I'm working with a family right now. Little one is 17, 18
Yeah.
months. And they're like, no, well, they're not showing any signs of low iron. Mom had low iron in pregnancy. I'm like,
Yeah.
see, actually a lot of signs here.
It's really,
But
really
yeah,
frustrating. Yeah. And I like in other countries too, outside of, there's a mom that DMs me a lot and she's been DMing me for like the 3 years that I've been doing this. And where she is, and I can't remember where that is, but they like don't believe in reflux. So like she can't get any support. Of course, now her child is older, so some of that has gotten better. But like, what do you mean? What do you mean you don't believe in reflux? And my husband is like, well, you should empower people to fly here. Like, who can do that? Who can come here? Some people can, but like it is crazy. And like here's a problem too. It's really difficult. I had a friend reach out to me a few months ago and she was worried about iron and ferritin and the ferritin came back low. And so we did like a quick chat, like here's what they're going to tell you, here's what you need to say to get what you need, and here's what they need to do, all of the research that I have, and here's this pamphlet that I made. And like she texted me after the appointment and she was like, oh my gosh, my pediatrician said everything that you said and we have a prescription dose. And like it was the first time in 3 years that I had ever heard of a pediatrician like taking that seriously. And like she was like, we need to recheck in 12 weeks. And so like it's just, it's the first time I've ever seen that, because usually it's
good to see.
Yeah.
Now, I've had families, definitely in different, I want to say countries, where it was just standard. They started offering iron supplement to infants around 6 months of age. Because it's like 7 to 12 months, it's like 11 milligrams of iron a day,
Yeah.
which is like really hard to hit anyways.
Yeah.
So I know we offered one just kind of periodically to ease my mind, because solids were always, again, a challenge for my youngest and stuff in general. So, and then once we got around to actually testing, yep, sure enough, it was still low. Obviously, with how the medical system is, you definitely have to advocate for your child. Like that's a big thing. Like, do you find that you have parents going through multiple medical professionals to get what they want?
So I have a lot of parents and friends that come to me, and so they come with like one finding that is crazy. Like we can use this like ENT who's saying that six apneic episodes in the night is no big thing. Like obviously you need a second opinion there, or like this ferritin thing. The trick with ferritin, if you have someone that's not doing the right ferritin protocol, is you go to a sleep specialist who is a pulmonologist. So it's pulmonology that you go to. So like, yes, and you kind of have to like know where to go to like work around, which really sucks. And I think like, I don't want to say that like, well, parents really have to do all this digging, because how would you know that? Like the reason I know that is because I worked in it and then I lived in it and I have some resources. But if you don't know that, a lot of the families that I work with, like before an early intervention appointment, we have a call and we go over language and how to not talk their child out of qualification, because that's easy to do. And before they have an ENT appointment, we have a 30-minute call where I tell them this is what they're going to say. That like, it's just really predictable at this point. Like, this is what they're going to tell you. Like, here's how they're going to gaslight you. And like, I don't want to be that way. Like, I know why they're doing it, because it's really hard and you don't want to put these tiny babies or 2-year-olds like through all of this stuff. But it's also not appropriate. Like when we're talking about tonsils, like if you have a child that's apneic in the night and their oxygen saturation is dropping in the night, you can't say, I'm not going to remove tonsils until they're 3 or 4 when they're 9 months. They're just going to be symptomatic for the next 3 years. Like that is crazy to me, especially if they're desatting.
Yeah. It's not realistic to expect a parent having to be dealing with that.
Yeah, no, it's really hard. It's really hard. And I don't necessarily know what the right answer is. I do know that like this thing that I'm doing has turned mostly into like nurse navigator. Like I spend far more time helping parents navigate medical appointments than I do sleep. And so we do like this first call and I go over I'm going to tell you all the red flags and we are going to like focus on these things. And then here's all the sleep stuff. And I write it all down for them so they have it. Cause you can do whatever you want to do. But if there's a barrier there, if there's a red flag, like you can be doing all the right things and not see any improvement in sleep. Like mostly what my calls are, and I have a lot of parents that will schedule multiple calls because now I'm going to go see the ENT and oh, this is the response I got about ferritin. And we just have to like hop on the phone and I've got to send them some resources, and that's sort of how we navigate that. But it's tough because like the average person wouldn't know, like, and you go to your doctor and you trust them, like you don't even know to question that. It's just like you saying like, I used to be a sleep trainer. Like you don't know what you don't know until you know it. And unfortunately for most people, something's got to happen before they learn what the bad outcome side of that is.
Do you want to talk a little bit about the attachment aspect, long-term outcomes in regards to sleep?
Yeah, so when we're talking about, so specifically we can talk about like an autistic baby, because that is where I see a lot of sort of disconnect, because we know developmentally typical children, like their attachment drive is like pretty standard. So infancy is proximity, toddlerhood is sameness, preschool is like belonging. And so when we're wanting to fill that connection cup, and connection is a huge piece of sleep. So if you're lacking like those connection needs, the sleep is impacted. But when you have an autistic child, it can feel counterintuitive to parents because they're not connecting in that same way. So that sameness isn't there. Perhaps the proximity is not there. A lot of babies with tactile sensory sensitivities like don't want to be snuggled, but want to be aggressively bounced. So like it can just kind of feel distant to parents and very counterintuitive. So once we get past year, I think before a year, it's sensory focused. So if you can get an OT on board and really get a good understanding of their sensory profile, then you can meet their needs for proximity that way based on their sensory needs. And after a year, we want to pay attention to things like stimming. So if you have an autistic child that's stimming, where are they stimming out of joy? Where are they stimming out of like, I'm overwhelmed? And can we decrease the things that are overwhelming them? And can we join in on the things where they're stimming in joy? And by join in, I mean like doing what they're doing. And so for like our son likes to look at water like really close, like running water. So it feels silly to me to get this close to the faucet and like watch the water run, but he loves it and it's so exciting to him. And like, that's how we're connecting. If you can,
that's connection.
Right? Yeah. So if you can use stimming and then special interests. A lot of autistic individuals have very narrow special, like just a few special interests, and they know a lot about them and they want to talk about them every day and all the time. And so for us right now, it's Easter. And so on some weekends, we're doing Easter. Like last weekend, on Saturday, I think it was the weekend before last, we did Easter, an Easter egg hunt, Easter crafts, Easter food. And so we have all these Easter things and he's just all about it, and the eggs and the toys that come inside the eggs. And so for him, like that's connection, and it's not really like, I guess that is kind of belonging, but like it's not like typical what we like. If I were helping a baby who weren't autistic, like I would, like for sameness, I would be like, wear the same pajamas, like eat the same snack plate before bed, like make them feel sameness with you. And that can miss the mark when you have an autistic baby. And another piece of that is like a play therapy lens. So like if your child likes to sit on the floor and I don't know, so you just start doing whatever they're doing. So if they're sitting on the floor, you sit on the floor, and then you like compliment how they're sitting on the floor. And then so you give them that praise, like I love how you're sitting, and then you just do whatever they're doing, but like not as well. And so we just had Dr. Sam and Dr. Christine from the neurodiversity docs in my community as expert guests, and they explained this really well. And I think there's a clip of it. If I haven't posted the clip of it, I will, and I'll send it to you and you can link it in the show notes, because they did like a role play scenario of this. And since then we have done it and it has worked really well, because your child guides you the whole time. Like you don't ask questions, you just sort of guide them, and it's a really nice connection time. But it can feel different for autistic children, and that can be hard for parents to navigate.
Yeah, I love that. Those are all just such simple tips that, you know, you wouldn't even really think about. What are your thoughts on melatonin and autistic children?
So there's a lot of research, and some of it is conflicting. So there's some that suggest that it's not produced enough. So there's like a lack of the hormone melatonin, and in those babies, like a melatonin supplement would be helpful. And then there's also research that indicates that there's a lack of melatonin receptors. And so if there's a lack of receptors, it doesn't really matter if you supplement because there's no receptor for the hormone. So I think that there's multiple things at play. Also, there's like absorption and metabolic differences in autistic children. So if you are going to supplement with melatonin, I would talk to your provider about it and start low and slow while you're doing it, just because sometimes they're more sensitive to supplements and medication.
That makes sense. Do you find screen time helpful for bedtime? Because I've had that introduced with some kids, and like with Luna, my youngest, screen time is we have to have a cutoff time. She's very, very overstimulated. It has not been helpful in any way, shape or form. But my nephew, who is autistic, he tends to fall asleep with a tablet. Yeah. And I don't know what your thoughts would be on that.
So we do... In our house, we do screen time. So for our 18-year-old, I'm going to talk about his sleep for a second because I think it is a testament to how impactful screen time can be. I was really resistant to it because you hear about how bad it is. And he was much older. Let's see, he was 12. So it was probably 15 when we did this. So I was in a support group. The support group was led by autistic adults, and many of them hold the belief that they should just have unlimited screen time. They'll learn to sort of self-govern it. But like that dopamine, like it really like helps their nervous system. And our oldest would not sleep. Like he would be up stimming and bouncing and doing headstand, like really sensory seeking until like 2:00 in the morning. And so one summer I was like, well, let's just try it. And it was probably a week where he was very tired and he was on it all night long. But then he did self-regulate, and instead of being awake until 2 a.m., like stimming in his room, it takes him like 15 minutes to fall asleep. So now he just has his iPad and he plays these noises that he likes on there, and it just stays on all night next to his bed with those noises, and we've had no issues since then.
And it works.
So I think like it really depends on the kid because it can be really overstimulating and dysregulating. And if you have a child that struggles with transitions, that is like a novelty. Like it is like such a big deal. And when you have to transition away from it, it can cause a lot of dysregulation. That is the case for our middle. And it is really not the case for our other two. And so like when I do our morning transition with our 4-year-old, he gets the iPad right away, eyes open, chocolate chip muffin, iPad. And then he gets 10 minutes to there's one certain show that he watches every single morning, and he just gets that, and we can transition away from it. I'll also say that like we went through some like pretty extensive speech therapy. At one point he was seeing 3 speech therapists. He had apraxia of speech. And allowing him to have an iPad, which I was, again, really resistant to, really like changed everything for him. So it like connected to him to his older brother, our middle son. Like they really got involved in like Minecraft. And so for a while we had like this Minecraft special interest, and they were really able to connect with that. And that connection with like a sibling like really promoted language development. So I think you have to like look at the big picture and like see what you're using it for. And like he doesn't learn in the same ways that I would say typical children learn. So we do a lot of like our homeschooling lessons on the trampoline. He's jumping and I'm standing. But a lot of like reading things, 8 words, writing, like he really is able to do those with ease on the iPad and not at a table. He really struggles with table work. And so the iPad's been really great for that. So, yeah,
that's awesome.
I think it's complex.
No, I agree. And I mean, they're all so different.
Yeah.
And my oldest too, she's definitely more sensitive, like emotion wise, but she can happily fall asleep watching a show, or we can turn it off and she's like, okay, I'm good.
Yeah.
Like no problem. But with him, it's a completely different story. So I've always been kind of, depends on the child with the screen time stuff. So
and it's hard to say it depends on the child when those 2 different childs live in the same home, because then you're making like different rules for different children. So that is a challenge.
It's hard for sure. Yeah. My oldest is pretty understanding. She's the same thing with her. Like she's fine. She can have sugar before bed. No problem. The other one, bouncing off the walls. I think dyes definitely affect both of them, but yeah, the sugar in general is just it's not good. So she's pretty sneaky about it. It's like, okay, but yeah, you have to go. You can have some candy, but not near your sister, please.
Yeah.
But I still feel so bad because the younger one wants it too, but I'm like, no, you will not sleep.
Yeah.
There's no way.
Exactly that.
I'm like, there's ice cream in the house. We get that before dinner.
Yeah.
and then you have dinner
Yeah,
afterwards.
and
I'm
like
like, who did that
what a
for?
way to be accommodating. Like
Yeah.
it's not what traditional, but like
No.
that's what works. So, yeah.
I think many parents, they blame
Mm-hmm.
themselves when sleep is not going well. Is there a message that you would want to give to parents who are struggling with their child's sleep?
For me personally, the feeling that I was like doing something wrong or failing or like something was wrong with my baby when I was sort of navigating all of these sleep issues, like was really had a really negative impact on my mental health. Like it really impacted my postpartum anxiety and postpartum depression, like the first year of his life. And at the end of that, on the other side of that, we learned that there were all of these other things going on. So there was autism and apraxia and low ferritin and oral ties and all these other things were going on. And so I just want parents to like sort of be able to like step outside of this moment and like realize that they're like this is such a complex big picture. And like when you get online and like all these holistic sleep accounts are saying like this is biologically normal and this is, but that does not mean easy, and it doesn't mean that there aren't like coexisting factors. And like I guarantee you that one of the things that is the problem is not you, like you showing up for your baby, you responding to your baby, like that's always going to be the right thing no matter what outcome. Like at the end when you come out of this and you have hindsight is 2020 vision, like you were not the problem, and you just really can't see that until you're on the other side of it and you have more information. It's really hard to know, especially that first year, like when they can't talk, like they can't tell you, so you're guessing, and it's not you. You are not the problem. Yeah.
Yeah. It's interesting too because there's this spectrum of like just waiting it out and not doing absolutely nothing. And like, yes, we do talk about, biologically normal infant sleep.
Yeah.
It does have to be a little bit sustainable
Yeah.
and stuff. And then you have the other side where it's just like, no, just leave them to cry it out and figure it out on their own. And it's so
Yeah. I
frustrating.
mean, I think the message though is like there's so many things you can do, and that's why I get so frustrated because like you get on these spaces online and parents are like, I had to go to work, I had to do something. Sleep training did not have to be that thing because there are like hundreds of different things you can try and different setups and things you can rule out and ways you can support your baby's sensory and nervous system need that like greatly impacts sleep. So if you're a new mom watching this, like know that there is definitely, if you have to go back to work, there are definitely other options. So you don't have to resort to that one if it doesn't feel good to you.
Absolutely.
Yeah.
Do you want to talk about just where families can find you and all the resources and stuff that you have?
Yeah, so I am at spiritedbabysleep.com or Spirited Baby Sleep on Instagram. I have a free resources tab and I've made some freebies there. My most popular one is the accessing services one. I'll give you that link, but like some other common issues like my baby hates the car seat, like, so I have some of that stuff there from like a sensory perspective. And then I also have my early neurodiversity community, so that is where I meet with parents inside the community. We do a Q&A every month, we do a workshop every month, and then I try to have an expert guest every month. Technically it's quarterly, but I can't help myself. So yeah, I'm in there a lot, and you can direct message other parents, you can direct message me, so it's great.
Thank you so much for coming and chatting with me today.
Yeah, thank
it
you
was
for having
so
me.
helpful. Thanks for joining us. Don't forget to connect with us beyond the podcast. You can find me on all social media platforms at moonbay.sleep. And for more sleepy goodness, you can head over to Instagram and follow Eleni at Rooted in Sleep. Until next week, keep embracing the chaos.